right? So this is a slightly different setting from what we've seen before in that it's not hospital operations at all. It's more like system or like behavioral personalization in a resource-limited setting. And so I've gotten into the habit when I speak, particularly to a broader audience, of sort of motivating doing operations, management, research in healthcare in resource-limited settings. And some of this is sort of stating the obvious, but I thought I'd mention it anyway. So first of all, if you take sub-Saharan Africa, for example, as an example of a resource-limited setting, clearly there is significant opportunity to have some impact there, right? So making an impact is hard, but if you're able to do it, it's very meaningful. The second part, and I think this is somewhat recent developments, is that for a lot of the big problems in global health, the problems are not medical anymore, they're not technological anymore. Increasingly, they're not even financial, right? So with the Gates Foundation, Clinton Foundation, and other organizations, we even have the funds to provide, for example, vaccines, right? But the problems are operational, right? And so the tool set that we have developed can be very useful in this setting. And on top of that, and for similar reasons, data is increasingly becoming available, right? So we're able to do the type of analysis for this setting that we weren't able to do 20 years ago, right? But people are already doing in hospitals, right? So I'm not arguing we should stop working in hospitals, obviously, but I'm arguing we should do some of this as well, right? And the final bit is that I think we as a community can learn from these situations, right? So there are systems that have been set up purposefully in, for example, sub-Saharan Africa that are very different from what we're used to, but will allow us to learn some things. And I think what I'm presenting today is actually a good example of this, right? So the way me and Justin, who is a proud graduate of the University of Toronto, and Erez, who is my colleague at Sloan, come at this is there's this sort of reasonably vast literature on personalized treatment choices, right? A lot of people are working on health analytics for personalized treatments, but we were interested in doing some personalization work for behavioral health, right? And this setting sort of allowed us to do that, even if it's very different, and even if it's very different from behavioral support tools that we might use in Canada or the US, I think some of the insights and methods will translate. Okay?